What do you see? What do you see, nurses? What do you see? What are you looking at when you're looking at me? A crabby old woman, not very wise, uncertain of habit with faraway eyes, who dribbles her food and makes no reply when you say in a loud voice, "I do wish you'd try." Who seems not to notice the things that you do and forever is losing a stocking or shoe. Who, resisting or not, lets you do as you will with bathing and feeding the long day to fill. Is that what you're thinking? Is that what you see? Then open your eyes, nurse. You're not looking at me. I'll tell you who I am as I sit here so still, as I do at your bidding, as I eat at your will. I'm a small child of 10, with a father and mother, brothers and sisters who love one another. A young girl of 16 with wings on her feet, dreaming that soon now a lover she'll meet. A bride soon at 20, my heart gives a leap, remembering the vows that I promised to keep. At 25 now, I have young of my own, who need me to guide and secure a happy home. A woman of 30, my young now, grown fast, bound to each other with ties that should last. At 40, my young sons have grown and are gone, but my man's beside me to see that I don't mourn. At 50, once more, babies play round my knee. Again, we know children, my loved one and me. Dark days are upon me, my husband is dead. I look at the future, I shudder with dread. For my young are all rearing young of their own, and I think of the years and the love that I've known. I'm now an old woman, and nature is cruel. 'Tis just to make old age look like a fool. The body, it crumbles. Grace and vigor depart. There is now a stone where I once had a heart. But inside this old carcass a young girl still dwells. And now and again my battered heart swells. I remember the joys, I remember the pain, and I'm loving and living life over again. I think of the years, all too few, gone too fast, and accept the stark fact that nothing can last. So open your eyes, people. Open and see. Not a crabby old woman. Look closer. See me. Anonymous. Geriatrics is a branch of medicine that deals with the physiological and psychological aspects of aging and the diagnosis and treatment of diseases affecting older adults. Geriatric nursing focuses on the care of the frail, sick older adult. It focuses on dependence of the client on the action of the nurse. Gerontology is defined as the study of all aspects of the aging process and its consequences. Gerontological nursing is concerned with assessment of the health and functional status of older adults, diagnosis, planning, and implementation of health care and services to meet the identified needs, and then the evaluation of the effectiveness of such care. This is the term that is most often used by nurses that specialize in this field. Gerontic nursing is a relatively new term that's meant to be more inclusive than geriatric or gerontological nursing. It's not limited to diseases and scientific principles, but is the art and practice of nurturing, caring, and comforting. While it's not widely used, it is viewed by some as a more appropriate description of the specialty. And ageism is bias that discriminates, stigmatizes, and disadvantages older people based solely on their chronological age. Simply put, it's discrimination against people because of increasing age. Our definitions and our thoughts of what comprises an older adult is based on culture, family, personal experiences, what other people might tell us, education, and employment experiences. Aging is determined by society and culture. The definition of old is changing. Back in 1935, old was considered to be 65. In the 2000s, it's now considered to be 70. Chronological age has little relation to the reality of the aging process for older adults. It depends on when the client was born, his or her history, gender, health, and ethnicity. This is because a person ages in his or her own way. As a nurse, you have to remember to approach each older adult as a unique individual. In today's world, we live a lot younger. Middle old is considered to be 65 to 74 years. I'm sorry, that was young old. Middle old is considered to be 75 to 84 years. Old is 85 to 99 years. And sometimes they're referred to as the frail elderly. This is the fastest growing group of the four. And elite old is 100 years or more. Biological age is grouping people by years of life, and it can be useful in some circumstances, but not in others. Not all 65-year-olds are going to be the same. Physically, individuals are affected by their lifestyle and the disease that affects their aging. Comorbidities, multiple chronic illnesses, lifestyle, tobacco, drug, alcohol use, sexual practices, exposure to sun and chemicals can all affect how rapidly a person ages. And if you stop and think about it, there's a lot of difference between someone who's 65 and the next person who is 65. Developmental stages, later life stages encompass all persons age 65 and above. There is a great difference between people aged 65 to 75 and 75 to 85 and 95. Just like there's a lot of difference between a 2 and a 3-year-old and a 3 and a 4-year-old. Psychologically, aging is expressed through a person's ability and control of memory, their learning capacity, skills, emotions, and judgment. So age 65 is actually an arbitrary beginning boundary for old age. Americans that are 65 years of age and older has actually tripled in the last 100 years. 1900, 4.1% or 1 in 24 were aged 65 or older. 2006, 12.4 or 1 in 8. In 2030, it's projected to be 1 in 5. In 2050, persons over 60 years of age are projected to exceed persons 15 years and younger in the United States. So, why does this age group continue to grow? Well, there is an increase in lifespan. We have better medicine, better treatments, better diagnostic testing, better water and food supply, and a decrease in infectious diseases. Diversity is also increasing due to immigration and naturalization. The majority of older adults will enjoy good health, with only 20% reporting a chronic disability. A vast majority live with a spouse, on their own, or with family, so they're not in long-term care homes. So why do we take time to study the elderly population? The population, once again, over 65 years old in 2001 was 13% of the American population, and in 2030 it's expected to increase to 22%. So in other words, they're continually on the rise. We have a lot of aging baby boomers. These are people that were born between 1946 and 1964. They have a hectic, fast-paced lifestyle, and many of these people had career before family. So they're not the same as what we grew up thinking of as old. Again, we have an increasing diversity with minorities. The most prevalent ones are going to be your African Americans and Hispanics, American Indians, Eskimos, Aleutians, Asian Pacific Islanders. And if you look at Kansas and Seward County, which would be liberal, we have over 50% of the population being Hispanic in 2007. Western Kansas has a high number of Vietnamese as well. And then we also have an impact of illness and disability. Most older adults in good health and those with health issues tend to have greater than 2 chronic illnesses or conditions. Looking at the leading causes of death in the elderly, we have to look at health. It's influenced by culture and age and looking at the functional abilities of a client. Wellness incorporates the person as a whole and includes physical, mental, and spiritual. More than 1/2 of deaths in persons age 65 and above are related to heart disease and cancer. And this is due to improvements in prevention and early detection, because due to improvements in prevention and early detection, these numbers are beginning to decline. The heart disease declined 6.4% in 2006, and cancer declined 2.9% in 2006. Most of these conditions can be managed or problems reduced by lifestyle changes, such as reducing weight or healthier nutrition with a reduction in fat, increase of complex carbohydrates and fiber, especially the fruits, vegetables, and grains, and increasing calcium and vitamin D. And remember that vitamin D can be obtained through sun exposure, 10 to 15 minutes, 2 to 3 times a week. Improvement in exercise, yearly health examinations, stress management, socialization, and reminiscing can also decrease death rates. The older population will experience fewer acute illnesses than younger age groups. This means a lower death rate. However, older people who develop acute illness usually takes a longer time to recover and have more complications. Chronic illness is a major problem for older adults. They tend to lead to increased limitations in activities of daily living or instrumental activities of daily living. Chronic conditions lead to high healthcare costs, and they are not only major sources of disability, but they are also leading causes of death. So let's look at the baby boomers. There is a growing number of persons older than 65 years of age, and it impacts the health and social service agencies and healthcare providers dramatically. Baby boomers are rapidly entering this age group, and along with them will come an increased demand for practitioners. We really need to get acquainted with this clientele. We began facing the onslaught in 2011, or if the person retired at age 62 back in 2008. Most have children, but they had fewer children and they waited until they were older before they had them. They usually experienced a higher income because of a 2-income household. While leisure time may have been scarcer and they have an increase in stress-related illness, they are the inventors of the fitness movement, and they tended to exercise more. They are highly knowledgeable consumers, and they take an active role in their health care, and they're also more interested in alternative medicine. With an increase in the aging population, increases in chronic diseases and disabilities will come higher health care costs. With available health services, we have limited number of practitioners, and few have the expertise in response of the older adult to diseases, etc. We need more assisted levels of housing, and traditional long-term care facilities will house the very frail. Available funding. We look at Medicare, which will assist with basic healthcare costs. They have 4 different programs in Medicare. A is the acute care short-term rehabilitation care. B covers the cost of the physician, nurse practitioner, and outpatient services. C is the Medicare Advantage plans, where a client can obtain additional coverage, and those offerings are usually based on what is available in their geographical location. And D is the optional prescription coverage. We look at Medicaid, which is federal and state funding. The dominant public payer for long-term care costs for the poor, and eligibility for Medicaid varies. It can cover more services than Medicare. Private funding is self-pay, where out-of-the-pocket expenses are paid, and they average about 33%. Medications may be in the hundreds to thousands of dollars per month. Some elders report that it's better to be poor than to have planned for retirement because of the cost of self-pay. We have Social Security, which is an age entitlement program that clients pay into throughout their younger working life. Usually it's not adequate to support the client. And veterans. Benefits cover active duty and retired military and their dependents, but there are some restrictions that apply, and the problem is usually going to be service related. Excuse me. Pension is also received by the retired in the military, and they have the option of a TRICARE healthcare program, which covers services that are not covered by Medicare, and they also have long-term care insurance. We look at the high cost of diseases, lifestyle choices, wellness versus illness, medications, long-term care or assisted care, and the technology. We have limited resources, older persons that have limited finances versus the elderly. So then you have to look at who's going to get limited or expensive resources, such as donor organs or expensive medications. Do we base that strictly on their ability to pay? There's a lot of myths and stereotypes out there about older adults. With all the talk of increased numbers of aging individuals, increased chronic illness, etc., they are bound to develop. These myths and stereotypes can be positive or negative. Most often, beliefs tend to be negative. We look at the elderly as being wise or to be honored, or we look at them as to be useless and to be avoided. Sick, disabled, physically unattractive. Many of the elderly have one or more health-related problems. Another myth is that 26.2% that one is not a myth, that one is fact. Only 26.2% describe their health as fair or poor. And they do enjoy sexual relationships. We look at the elderly as being forgetful or confused. But don't forget that sometimes our perceptions are based on changes in their vision or their hearing ability. We might see them as being rigid, boring, or unfriendly, but we have to realize that they still have much to offer and share. Think of the phrase, "We are as we were, only more so." We look at the elderly as being unable to learn. Oh no, they can still learn. It just might take a little bit longer. But be sure that you include teaching aids such as large print or visual cues. The elderly live in nursing homes. Only 4.5% live in institutions back in 2002. They're poor. Well, 10.2% have incomes below the poverty level. 6.7% are the near poor level, and 90% receive Social Security. And we look at them as being worthless. They may not work a 40-hour week, but many are able to volunteer at schools, churches, care facilities. They work part-time, etc. They still contribute. Look at these factors and stereotypes of aging. And how do these factors affect our beliefs about aging? So what do you think? Any of you still have great-grandparents who are living? A person in need of the assistance of others is at risk for harm and injury at the hands of a frustrated, angry, fraudulent, careless, or disturbed caregiver. These caregivers might struggle with frustration, anger, fraud, and carelessness in giving their care. Mistreatment can lead to abuse, and most abuse cases are going to occur in the home setting. Most abusers are the spouses or adult children. The largest incidence of elder abuse is in Caucasians. Abuse tends to be episodic and recurrent, and it's not isolated. The victims often attempt to dismiss the injuries as accidents. Risk factors to be or become an abused or abuser are people abusing substances, people that have mental or emotional illnesses or physical disabilities, people that have a history of abusing or being abused, exhausted or frustrated caregivers. Caregivers may be abused by the elder. Older women, people who are more dependent or vulnerable. They live alone with an abuser. They're socially isolated by that abuser, and financially dependent upon the abused. Categories of abused are domestic abuse, which will take place in the home, and it's usually carried out by a family member or a significant other. It includes physical maltreatment, neglect, or abandonment. Institutional abuse takes place in a hospital or long-term care facility or a facility other than the home. And self-neglect, which is a lack of caring for oneself by mentally competent individuals who is cognitively competent, but who engages in actions that negatively affect his or her personal safety. Nurses are mandated reporters and must report suspected cases of abuse or neglect. These reports are usually anonymous. And again, just because you're a student does not relieve you of that mandated reporting responsibility. Nurses must be vigilant in their sensitivity to the potential for abuse, observing for signs and symptoms in all their interactions with vulnerable elders. Looking at family dynamics, approximately 100 years ago, family consisted of parents, grown children, and or grandchildren. They often lived together, sharing their resources, their strengths and challenges. And some cultures continue to have the extended family or ethnic neighborhood. We look at traditional family, where cities grew and children began to move away. The traditional family then consisted of husband and wife and children. Today's family, some married couples might not have any children. You see a lot of single-parent families or blended families, or same-gender couples with or without children, communal families with siblings, friends, etc. And understand that some adults will never marry. Often they might be more financially stable or work longer in life. They may be more resilient due to their independence. Excuse me. Transitions. We have retirement. 44% of retirees work after retirement. Retirement planning can ease the burden of retirement and includes preparations for retirement such as financial security, health care, etc. We look at role changes such as grandparenthood. Many grandparents are now taking on the role of parent to their grandchildren, or they take a more active role in the lives of their grandchildren, up to in providing childcare. Grandparents are frequently younger or freer and are able to be more involved in the lives of their grandchildren, and this provides a lot of emotional satisfaction. We might see strained relationships caused by children being preoccupied with their own lives, or unmet needs, conflicts, or resentments from the past can start to fester and cause new resentments or issues. Siblings, especially sisters, tend to become closer in older age, but we cannot ignore fictive kin. This is the non-blood relationship that might be closer emotionally than biological family. The elderly begin a life review. Some experience widowhood. We look at 76% of women age 85 or older as being widowed. This results in a social status change, changes in economics, and changes in self-image. They may be divorced. They're on a fixed income. They have health changes. They've become a caregiver or a recipient of care. Families, unpaid caregivers, provide 80% of older adult care, with 66% being female caregivers. Caregiving is a major public health issue, and there's increased stressors that lead to poor health, compromised immune function, and increased mortality, etc. Many older adults care for disabled adult children. Adult children frequently will provide intermittent or continuous care of older parents or aging relatives. But spouses and siblings also provide some of this care. So we have to look at nurses' attitudes toward the older adult. You need to incorporate Maslow's hierarchy of needs in the treatment of older adults, striving to meet needs and ensuring client function is at the highest level of wellness possible. Most attitudes are based on our own experiences, and we bring this to our profession. Unfortunately, it can be positive or negative. We think that what is true of one is true of all, but it's not that way at all. More and more research is being done, and results are available for our use. For example, we have available the Journal of Gerontological Nursing and Geriatric Nursing to review. Nursing assessment is important in order to see the client as an individual with individual strengths and needs. Not all elderly are hard of hearing. Not all of them take a lot of medications, and many of the elderly are very positive about their life. We have to work to alleviate our personal biases and leave those biases at the door. Look at the person as an individual. What is the story of their life? Many only received a 6th grade education, but does that mean they're ignorant? It may mean that they were sent away to work. Never assume that they are uneducated.